Hello, everyone. This educational seminar will focus on a brief update for healthcare professionals during the COVID-19 epidemic. The education is intended for healthcare professionals such as RNs and EMTs. My name is Jackie Christensen. I'm a nurse practitioner who is currently contracting in New York City to help with patient care and management during the pandemic. I've been in emergency services for about 13 years now, and I have worked as an EMT, an ED tech, and as an RN prior to becoming an NP. So hopefully this information in the presentation will be helpful to you all as we navigate this course together. Objectives are as listed on the PowerPoint slide. The overarching goal of all this is to give you the knowledge and practice recommendations both to keep yourselves safe during this pandemic and to help as many patients as you possibly can, and just understand some of the practice changes for COVID-19 patients specifically compared to our other normal guidelines such as sepsis guidelines. COVID-19 is a viral disease that's multifaceted and affects many systems. It has a variety of names, including just the coronavirus. It's also called SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome, of which this current coronavirus is the second iteration. Symptoms of COVID-19 have a whole variety of symptoms. They can include, throughout the various course of illness, respiratory symptoms like hypoxia, difficulty breathing, and respiratory distress, cardiovascular symptoms like chest pain, constitutional symptoms like fever, general malaise, fatigue, and body aches, and GI symptoms like abdominal pain or diarrhea. And many patients can actually be completely asymptomatic or minimally symptomatic. So that's something to keep in the back of your head too, that even somebody who's not necessarily presenting with these symptoms may in fact actually have COVID and they're simply asymptomatic from it. Something else to consider is that a lot of COVID-19 patients' symptoms evolve over time. So they may start out with abdominal pain or diarrhea that goes away after a few days, but they then eventually develop some of the respiratory symptoms or some of the constitutional symptoms like fever. Another thing I'd like to point out is that the hypoxia that comes with respiratory symptoms are not necessarily always, they're not always associated with shortness of breath. We're seeing a lot of patients come in right now who have hypoxia but aren't reporting any shortness of breath or any cough or any exertional dyspnea whatsoever until they become more severely ill. So hypoxia by itself can actually be one of the warning signs that COVID-19 is what you're dealing with. So keep that in the back of your head as well. Best evidence seems to suggest droplet, contact, and airborne spread of COVID-19. While the airborne route is still being investigated, some recent studies do actually show detectable virus counts in exhaled air without coughing or sneezing, which is a likely indicator that this virus is transmitted via the airborne route as well as droplet or contact. Droplet and contact have definitely been more definitively established, and there's still more ongoing research to confirm that airborne spread of COVID-19 is indeed happening. At the time of this taping on April 11th of 2020, worldwide there were 1.7 million confirmed cases, 500,000 of which were in the United States alone. Of these confirmed cases, worldwide there have been 100,000 deaths, with 18,000 of those in the United States, and worldwide 400,000 cases have been confirmed as recovered. Note the earlier use of the word confirmed. Due to testing shortages and a high false negative rate for the nasopharyngeal testing route, which we'll talk about in a little while, the number of confirmed cases is actually very unlikely to reflect the actual number of confirmed cases, and indeed the actual number of deaths due to complications of COVID-19. Out in New York City, a lot of our critically ill patients actually died before their COVID-19 test resulted, or even before the test was collected, and many patient deaths are actually called in the field by emergency medical services and paramedics before they make it to the hospital, which means we're almost certainly underreporting the number dead from this virus as well. Additionally, the nasopharyngeal test has a very high false negative rate, as I mentioned just a few minutes ago. Anywhere between 20 and 50% is the false negative rate, depending upon how long the patient has been sick for and how the test was collected. The nasopharyngeal route is usually collected by putting a swab all the way back into their nasopharynx via their nose, not just a nasal swab like we've been doing for influenza. So just a simple nasal swab where you only swab the nair itself will often get a false negative, where a proper nasopharyngeal will not. It also depends on how long they've been sick for. We've been seeing patients with more false negatives that have been ill for the 10 to 14 day mark compared to patients who have only been ill and likely have fewer severe symptoms in the first week or so of illness. So keep that in mind. You can the rate at which the nasopharyngeal swab comes back positive it's a good way to confirm that yes, it's what they have, but it's not a good way to say no, this definitely isn't what they have, just because the likelihood of having a false negative is so high. Also, keep in mind that to the best of our current knowledge, there's a 4% critical illness rate and roughly a 1 to 2% death rate when adequate health resources are present. As you might guess with that death rate really does increase markedly if there are no available healthcare resources to care with the critically ill. And if the resources aren't available, the critically ill rate frequently can very quickly become the death rate. Finally, emerging research does seem to indicate that COVID-19 might be mutating. It's unclear if the different suspected strains that have been found can cause a new illness in somebody who's recovered from previous COVID-19 infection. However, mutation and reinfection with a new strain is definitely still within the realms of possibility. So it is possible, within the theoretical idea at least, that these patients could have COVID, get better, get reinfected with a different strain. We don't yet have enough research on that, and the research on the new strains existing by themselves is actually fairly new, so there will be a lot of evolving information on that coming out as the next couple months go by. So this comic just demonstrates the difference between droplet and airborne routes as far as routes of infection go. The left side shows the droplet route, in which somebody is exposed via direct coughing or sneezing that causes expulsion of droplets, where the airborne route is a route in which just inhaling the same air as a diseased person exhales can actually expose you to infection. Similar in nature to tuberculosis. So tuberculosis is a well-known airborne spread disease. Tuberculosis is the right. Influenza is a common droplet spread illness that's not airborne. Influenza is more the comic on the left. Bear in mind that this is part of why 6 feet of social distancing is recommended. 6 feet of space between you and an infected person, even with an airborne route, does significantly decrease the likelihood of your airborne exposure, because exhaled air doesn't really, first of all, it doesn't remain infectious indefinitely, and second of all, with a 6-foot radius between you and the sick person, there's a lot more room for that air that they've expelled to diffuse before you breathe it in. So that's why there's a 6-foot recommendation, despite some sources thinking that this is just a droplet spread only disease. This slide is more to demonstrate how contagious COVID-19 is. The R0 number, for those who aren't familiar, refers to what is known in epidemiology as the basic reproduction number, and it's a measure of how quickly a disease spreads. It's a number that's impacted by a variety of things, including nutritional status, the route of spread, implementations of policy like social distancing, and it's actually intended to be a functional number that reflects real-life spread, not a theoretical number that reflects how quickly we think that it will spread. So this is an evolving number with different diseases as pandemics happen. Ebola is an example. The Ebola virus outbreak of 2014 had an R0 of about 1.5 to 2.5. Smallpox, depending upon which outbreak you were looking at, had an R0 of about 5 to 7. And COVID-19 right now has an R0 of 5.7. Compare that to our seasonal influenza, which has an R0 usually ranging between 0.9 and 2.1. The Spanish flu pandemic of 1918 had an R0 of between 2.1 and 2.5, depending upon which blip in time you were looking at. So keep that in mind when you're caring for patients with COVID-19 and when we talk about personal protective equipment, because this disease is extremely contagious. This slide is a brief overview of the typical COVID-19 course of illness for a patient who does become severely ill or who perhaps even dies from COVID-19. The timeframes given on this slide are not necessarily always an accurate representation for every single patient, but it's just intended to give you a rough estimate of how the disease progresses, what rough time frame the disease progresses on, and how long patients generally seem to stay in each aspect of the illness. Do note the section's based on experience and observation, not based on data. While the experience and observation has been shared with numerous other providers across the United States dealing with COVID-19 patient surges, not just my own personal experience, do bear in mind that we're all subject to certain cognitive biases, and it's very possible we're missing aspects of disease course or incorrectly estimating timeframes. The stages that we're generally seeing, that all said, we're seeing on about anywhere between day 3 and day 12 post-exposure, we're seeing some influenza-like symptoms, so mild cough, fevers, perhaps very mild shortness of breath. Even the shortness of breath, we're not necessarily seeing this early. GI symptoms, so mild abdominal pain, abdominal cramping, diarrhea, nausea, vomiting, symptoms like that. The big one that we're seeing is diarrhea and some of the abdominal cramping associated with diarrhea, but we have definitely seen people with nausea, vomiting in this stage. And then early hypoxia, so perhaps their oxygen, their SpO2 is 92% on room air at rest, or it drops down into the low 90s with mild exertion, but isn't necessarily hypoxia that you would treat clinically. The second stage we're seeing is around day 5 to 7 of symptoms. So this is not post-exposure anymore. This is after they've developed symptoms. 5 to 7 days, they have some increased hypoxia, often in the low 90s, sometimes even the upper to mid 80s on room air. Certainly with exertion, they are dropping low. Mild shortness of breath you might see, particularly with exertion when their oxygen does tend to drop more precipitously. You'll sometimes see some very mild shortness of breath. Not every patient has shortness of breath at all, or either self-reported or observed in this stage of the disease. We're seeing bilateral viral pneumonias visible on the chest x-ray, and we'll talk a little bit more about what that chest x-ray read looks like in a couple of slides. The hypoxia that we see is not at all proportionate to the shortness of breath, either expressed or visibly noticed on your physical exam, that said. We're sometimes seeing some very early symptoms of DIC at this point as well. So we're seeing risk factors for, or suspicion for pulmonary embolus, for example, or some people in this stage are actually coming in with stroke-like symptoms because they've had an embolic stroke. So DIC does tend to set in relatively early with some patients, particularly patients who have vascular compromise otherwise. The patients with hypertension, the patients with known coronary artery disease, diabetic patients, people like that do tend to be a little bit more prone to DIC, it seems like, even before the cytokine storm really sets in. On the subject of cytokine storm, day 10 to 14 after symptoms again, cytokine storm tends to ramp up with associated respiratory distress and failure, multi-organ failure. Decline can be really rapid with these patients. We actually can see them decline within hours. I've seen patients go from only needing 6 liters of oxygen via nasal cannula to within an hour needing 15 liters via non-rebreather mask. Within another hour, they're on CPAP or BiPAP, and half an hour later, they're on a ventilator, and they're continuing to deteriorate even on the ventilator. So the multi-organ failure and the respiratory failure really does happen pretty rapidly with these patients when it does set in. This slide is an overview of COVID-19's disease physiology. Again, this is an evolving understanding, and this is informed currently by our best available evidence, both peer-reviewed evidence and observational evidence, but it doesn't necessarily represent what we may come to understand as the complete disease physiology, since a lot of this research is really still ongoing. Bear in mind that this information is the best that we have right now, but it's not necessarily going to be the end-all or what we ultimately find this disease does in its entirety. The most current research suggests that COVID-19 is primarily a hematopathy, or a disease of the bloodstream, and secondarily a respiratory illness. And I'll talk about how that works in just a moment, even though we're seeing patients with ARDS primarily. Research is increasingly finding that it's a hemophagocytic lymphohistiocytosis. I'm going to refer to that as HLH for the rest of the slide, is associated with COVID-19. So as a review, HLH is ordinarily a very rare syndrome in which macrophages and T cells in the immune system start recognizing the body's own cell as invaders. This leads to an uncontrolled activation of the immune system and attack on the body's organ system by the body's own immune system. Organ systems affected include primarily the most vascular organs that receive high volumes of blood flow. So you're looking at the liver, the lungs, the kidney, the spleen, and the blood itself is actually being attacked as well. We're seeing low counts of all the blood cells, including red blood cells, white blood cells, and platelet as HLH progresses, though we're not necessarily seeing those counts drop in some of the earlier stages of disease. So that 3 to 7 day time frame, again, we're not necessarily seeing low or even low normal counts of these blood cells, but we're seeing evidence that they're being attacked within the blood work itself. Under ordinary circumstances, HLH is extremely rare and really quite lethal. It's difficult to control because of the diffuse nature of the inflammation. We're seeing in the lab work, which we'll talk about in a couple of slides, we're seeing lots of very, very, very high inflammatory markers. This particular syndrome is so rare that it's not even necessarily covered in most nursing or EMS programs. So I know in my own career, I've actually never seen this syndrome in my 13 years of emergency services prior to COVID-19. So you may not have ever even heard of this syndrome necessarily before, but this is the syndrome that we're seeing happen. It does happen in a couple of other viral processes, and there's thought to be a genetic link in some cases as well. COVID-19 is one of the things that can spur this to start, though. HLH itself actually causes a hypercoagulable state, which makes the development of DIC, which we'll discuss in an upcoming slide in a little bit more detail, more likely. The cytokine storm associated with HLH is thought to be the cause of ARDS, or acute respiratory distress syndrome, as well, due to the damage and the inflammation it actually causes in the lung tissue itself. So you're kind of getting an attack on the respiratory system from two sides. You're getting the hematologic side of things. Your hemoglobin cells are being inactivated and they're being ultimately destroyed. So you have less capacity to carry oxygen during this disease. You're also seeing the lung damage itself and the impairment of the lung tissue to actually be able to function correctly. So it's kind of a double whammy as far as the ARDS go, and we'll talk about that in a moment or two. So again, we'll talk about DIC in more detail in an upcoming slide, but the long and short with DIC is that it's often a lethal complication of COVID-19, and the process of DIC occurs in two stages. In the first stage, the patient's in a hypercoagulable state. In this situation, usually from the HLH, and they start to form blood clots spontaneously, mostly in locations that are, again, very vascular, like the lungs, the brain, the liver, the heart, the kidneys. If the patient survives the formation of blood clots, and that's a tenuous consideration because a lot of patients do not survive the formation of blood clots, eventually they run out of clotting factors with which to form clots. That means that we're unable to form clots and heal microtears in their blood vessels, and that leads to severe hemorrhage, which can also lead to death. So DIC is a really pretty severe and difficult to manage condition because you're having to manage both the formation of blood clots, and you're also having to deal with the possibility of hemorrhage from these patients. So all of this, those two syndromes, HLH and DIC, make a certain degree of sense with regards to the disease course that we talked about. The immune system becomes turned on in the early stages of the disease, producing the symptoms consistent with non-specific immunity, like fever, diarrhea, coughing. As the disease progresses, we see increasing hypoxia, but not necessarily with much correspondence to respiratory distress. That's because the haywire immune system is targeting and attaching to hemoglobin, making it more difficult for the body to circulate enough oxygen and perfuse tissue correctly. It's also causing the body to produce more hemoglobin in response to lack of available oxygen, which we'll see in the lab findings consistent with COVID-19 in an upcoming slide. As the HLH continues to worsen, the patient develops respiratory distress, sometimes starts to spontaneously form blood clots because the HLH makes them more prone to clot formation and DIC, eventually develop ARDS due to both the lack of hemoglobin to carry oxygen and eventual damage to the lung tissue itself, and they often die despite best treatment efforts most commonly of ARDS, but they can also die of sequela of DIC. As a side note, at this point in the presentation, I'd like to just address the idea that your patients are sometimes going to die with this. I just want to make it abundantly clear to healthcare workers that they should not feel personally responsible for the deaths of these patients. Just know that many of these patients who develop severe sequela of this disease will die, and there's absolutely nothing we can do about it. Patient deaths are not a sign that you didn't do enough or that your care was in any way deficient, but this disease causes an unusually lethal combination of severe syndromes that alone are difficult to survive. Most patients with HLH honestly die, and most patients with DIC also die. We have a disease that is causing both of these syndromes together often. So just keep in mind that what you're dealing with is really kind of a larger than life, extremely high mortality syndromes, and these syndromes usually don't cause uncomfortable or easy deaths either. So if you do see patients that die, just know that this is not something that you caused or something that you contributed to in any way. It's just that you're dealing with something bigger than what we can realistically handle. For what it's worth, again, I've never actually seen HLH prior to COVID-19 in my 13 years of emergency medicine, and I've only seen DIC twice before. The best outcome of those two people was somebody who survived with some degree of multi-organ damage without complete organ failure, and she lost all 4 of her limbs. So you're you're really dealing with some pretty severe sequela of this disease. Just keep that in mind if you do have patients that do die or do abruptly deteriorate, and you may not necessarily know what happened to them. So we're really dealing with some pretty severe, difficult to handle consequences of this disease. Something that we'll talk about in another slide is just the possibility of having people have DNR or DNI orders. In consideration of the severity and the, frankly, lack of comfort in these syndromes, HLH and DIC both, as well as ARDS itself, as the sequela of those previous two, it's a really pretty horrible way to go, and it's a very difficult, either or both of these are very difficult to medically control. Their odds of survival once they've developed complications like this are relatively low, unfortunately. And you could consider it, as far as ethical considerations with asking about DNR and DNI orders to patients and kind of trying to make them aware that if they really do develop severe sequela of this disease, their odds of survival, even with the best medical efforts, are really relatively low. So having those conversations, and we'll talk a little bit more about DNR and DNI orders in a later slide. Just keep all this information in the back of your head when you do think about DNR and DNI orders for these patients.